Today's presentation is about dyspareunia. The definition of dyspareunia is defined as the genital pain that can be experienced before, during, or after intercourse. It is debatable whether this condition can be classified as sexual disorder or pain disorder, as identifying a specific etiology can prove sometimes challenging. Dyspareunia can have significant effect on physical and mental health, as well as quality of life. This activity illustrates the evaluation and management of dyspareunia, highlights the role of interprofessional team in managing patients with this condition. The objective of this presentation is to outline the patient history associated with dyspareunia, review psychosocial consideration for patients with dyspareunia, summarize the treatment consideration for patients with dyspareunia, describe how to counsel patients with this problem. Painful intercourse is common in female health problem. It is medical terminology, it's called dyspareunia. It is a complex disorder that often goes neglected. Prevalence of dyspareunia varies from 3 to 18% worldwide, and it can affect 10 to 28% of the population in a lifetime. Dyspareunia can be further categorized into superficial or deep, primary or secondary. Superficial dyspareunia is limited to the vulva or vaginal entrance, while deep dyspareunia means extension of pain in the deeper parts of the vagina and lower pelvis. Deep dyspareunia is frequently associated with deep penetration. Primary dyspareunia includes pain at the start of intercourse, while in secondary dyspareunia, pain begins after some times of pain-free sexual activity. Dyspareunia is sometimes intermixed with vulvodynia, a genital pain that lasts more than 3 months, with or without the association of sexual intercourse. Dyspareunia can also lead to sexual difficulty, such as lack of sexual desire or arousal, and can cause a trouble in sexual relationship. It can have a significant impact on physical as well as mental health. It can lead to depression, anxiety, hypervigilance, to pain, negativity of body image, and low self-esteem. So, prompt management is very crucial to address this problem. In this review, we'll focus on the etiology, epidemiology, evaluation, management, prognosis of dyspareunia. The etiology of dyspareunia encompasses structural, inflammatory, infectious, neoplastic, traumatic, hormonal, psychosocial condition. The anatomical causes include pelvic floor muscle dysfunction, uterine retroversion, hymenal remnant, pelvic organ prolapse. Lack of lubrication is the most common in reproductive years and is attributable to hormonal as well as sexual arousal disorder. For reproductive aged female, contraceptive can cause inadequate lubrication, whereas decreased estrogen level noted in postmenopausal women can cause the vaginal atrophy by thinning in the vaginal mucosa that is responsible for promoting vaginal secretion. Endometriosis is a condition in which endometrial gland and stroma are present outside the uterus. The etiology of endometriosis associated with deep dyspareunia could be due to endometriosis, a specific factor, or indirect contribution like the bladder pelvic floor dysfunction. In women, regardless of the staging of endometriosis, the severity of deep dyspareunia was strongly associated with bladder pelvic floor tenderness, painful bladder syndrome, independence of endometriosis specific factor, which suggests the role of myofascial or sensitization pain mechanism in some women with deep dyspareunia. Dermatological diseases such as lichen planus, lichen sclerosis, psoriasis can cause significant inflammation to the vaginal mucosa as well. Perivaginal and pelvic infections such as urethritis, vaginitis, pelvic inflammatory disease can result from gonorrhea, chlamydia, Candida, Trichomonas, bacterial vaginosis, viral pathogens such as herpes. Postpartum dyspareunia may occur commonly present after perineal trauma from delivery than those of an uncomplicated vaginal delivery with intact perineum or unsutured tears. Vaginismus is a common condition in young women and defined as involuntary contraction of pelvic floor muscle on attempted vaginal penetration and can be the result of pelvic floor dysfunction or psychosocial condition associated with sexual abuse. The incidence of dyspareunia mainly depends on the definition used. Therefore, population sampled. In the United States, the prevalence can be between 7 to 46%. Dyspareunia affects both male and female. However, it is far more common in the female population. Women with symptoms severe enough to require medical attention comprise a small subset, as most patients do not seek medical attention, making the true incidence rather challenging to determine. History and physical. Obtaining history in a non-judgmental way is very important and crucial and should include pain, description, duration, intensity, location, exacerbating, alleviating factor, and any associated psychological component. The location and onset can help differentiate entry versus deep pain, whereas burning pain more commonly links to vaginitis, vulvodynia, atrophy, inadequate lubrication, deep aching pain may be noted in pelvic congestion syndrome, pelvic inflammatory disease, endometriosis, retroverted uterus, uterine fibroid, and adnexal pathology. Situational versus more generalized description occur only with certain partner or with all encounters, may more strongly link psychological consideration. The impact, the initial measurement of patient-reported pelvic floor complaint tool form consists of different questions relevant to pelvic floor abnormality. It also helps in dealing with dyspareunia patient. In this first step of physical examination, it's always advisable to educate the patient about examination and her anatomy in detail. Then it should begin with visual inspection of the labia majora, labia minora, vestibular area, anus, urethral orifice to evaluate any lesion, labial hypertrophy, leukoplakia, or erythema. The spectrum exam should take place after selecting an appropriately sized the speculum exam, should take place after selecting appropriate sized speculum. Consider a pediatric speculum because of the patient discomfort. That is warmed and lubricated. Examine the cervix and any associated lesion, erythema, discharge, at which time appropriate cultures are obtainable. Bimanual examination should then be done to evaluate presence of cyst, adnexal mass, uterine mass, and additional anatomic problem. The evaluation rarely helps in guiding the diagnosis or treatment of dyspareunia. However, it is better to rule out abnormalities to reach the exact diagnosis. Since the pain in vulvodynia is similar to dyspareunia, it is better to rule this out by performing cotton swab test during the vulvar examination. Further tests can include pelvic culture for gonorrhea, chlamydia, trichomonas, candida, and Gardnerella, are indicated when women present with vaginal or cervical discharge. Genital ulcer can be tested or performed for herpes simplex, syphilis, or appropriate culture. Women with associated dyspareunia, urgency, frequency, suprapubic discomfort should receive a urine analysis. Visible lesions noted on physical examination should undergo tissue biopsy. Transvaginal ultrasound can help in evaluating pelvic mass, endometrial hyperplasia, ovarian cyst, congenital anomaly. Treatment and management. For treatment of dyspareunia, its multimodal treatment approach is advantageous to address all aspects of pain, physical, emotional, behavioral. It should involve a team consisting of gynecologists, pain management experts, physical therapists, sexual therapists, mental health professional with a specialization in chronic pain. In the first step, a physician should acknowledge the patient has pain. The patient should receive counsel in that pain management may take time, and it's quite possible that it may not completely resolve even after the completion of the treatment. Patients should be informed of all treatment modalities available and helped to choose that possible treatment option. Conservative non-surgical approach should be the first step. Medical treatment options are available for dyspareunia, including oral tricyclic antidepressant, topical hormonal replacement, non-steroidal anti-inflammatory drugs, Botox injection, cognitive behavioral therapy, other brain therapy. Treatment of dyspareunia depends on the etiology of the patient complaint. Dyspareunia due to postmenopausal vaginal atrophy can have treatment for systemic and topical hormone replacement therapy, selective estrogen receptor modulator therapy, and the use of vaginal dihydroepiandrosterone. Clinician can treat infectious diseases with appropriate antibiotic, antifungal, antiviral agent. Postpartum dyspareunia can respond to vaginal lubricant, scar tissue massage, or surgery for persistent cases. Botulinum toxin injection has proved to be effective in the treatment of dyspareunia caused by pelvic floor myalgia and contraction. Pelvic floor physical therapy can serve as an adjuvant treatment option in most cases of dyspareunia. It relaxes pelvic floor muscle and reduces re-educated pain receptor. Cognitive behavioral therapy has shown promising results in reducing anxiety and fear related to dyspareunia. It is the most commonly used behavioral intervention and is a strong recommendation. Surgical treatment is adopted as a last resort when all conservative medication behavioral treatment failed. It is usually useful in identifying or treat pelvic adhesion, endometriosis, and pelvic organ prolapse. In the differential diagnosis, to reach a diagnosis for dyspareunia, one has to rule out vulvodynia, vaginismus, atrophic vaginitis, vulvar vestibulitis, endometriosis, pelvic disease, uterine fibroid, pelvic congestion syndrome, pelvic inflammatory disease, endometriosis, and other urogenital infection. The prognosis of dyspareunia depends on the causative factor of this pain. If the underlying cause is known and curable, then it has better prognosis. Its prognosis is poor in idiopathic dyspareunia. Following treatment in patient dyspareunia should receive counseling about the prognosis of the disorder. Treatment can last several months, and complete resolution is also not guaranteed. Studies suggest that results start appearing after at least 3 months. After that, the patient distress should start decreasing and improve quality of life. 24-hour-month follow-up is recommended for the best results. Complication. Dyspareunia is usually treatable disease and does not result in major complications. Regardless of the non-malignant nature of the disease, timely management and intervention are crucial, obviating the distressing sequelae. If patients do not seek prompt, appropriate medical care, it can result in loss of sexual interest and problem with the relationship. It also results in significant distress and conflict among partners. Psychiatric issue may arise if dyspareunia remains untreated. Psychiatric issues like major depression due to dyspareunia are more prevalent in younger women. In few cases, fear of pain during sexual activity can result in female infertility. Deterrence and education. In general, patients are hesitant to discuss their sexual dysfunction, and it can go unnoticed for a long time. Patients should be encouraged to discuss their sexual health with physician. Dyspareunia is a challenging topic for the discussion of both patient and physician. It can also lead to suboptimal management. Clinicians need sufficient education and training to evaluate and treat patients with dyspareunia properly. It is important to allay patient fears and anxiety and provide reassurance for them to discuss this condition with their primary care physician, who can then refer them to the specialist guide for treatment depending on the etiology. Enhancing healthcare team outcome. Management of dyspareunia is a typical example of healthcare provider to ensure patient-centered care. The symptoms, physical findings, concerns related to dyspareunia are managed by collaborative effort of a team consisted of gynecologists, urologists, psychiatrists, pain specialists, paramedical staff. To standardize treatment, pelvic floor disorder come into existence, which also provide guidance to treat several other conditions. It reviews multiple symptoms, function, quality of life questionnaire. The PFDC is comprised of urogynecologists, urologists, gynecologists, physiotherapists, and other advanced care physicians that deal with the complex concern of sexual dysfunction. A multidisciplinary treatment approach has shown to be beneficial in treatment of dyspareunia. The general care physician usually initiates the connection with the patient and develop rapport. Adequate education regarding the course of the disease should be provided to the patient. A psychiatrist should be involved to relieve patient distress. Sexual pain specialists should also be offered when needed. Pelvic floor rehab has shown promising results in dyspareunia treatment. Hence, by team effort, healthcare outcome can improve significantly. End of dictation.